Winged scapula. Push both hands against a wall. If one shoulder blade lifts away from your ribs like a floorboard coming loose, the bone may look like the problem. It usually is not. And the real giveaway is not the bump itself. It is what happens when you move. Your shoulder blade is not bolted to your chest. It glides across the rib cage, controlled by a network of muscles that must keep it stable while your arm moves. One of the most important is the serratus anterior, serratus anterior. It spreads across the side of the ribs and helps pin the inner edge of the scapula against the chest wall. Think of it as biological Velcro. Its electrical signal arrives through the long thoracic nerve. When that nerve is injured, the serratus anterior may lose strength. The scapula can then peel backward, especially when you push against resistance. Other patterns of winging can involve the trapezius, the spinal accessory nerve, the rhomboids, or the dorsal scapular nerve. The shape may look similar, but the broken cable can be completely different. That is why the bump is only the surface clue. The deeper clue may be an arm that suddenly feels heavy overhead. A push-up may twist to one side. Reaching for a high shelf may feel as though your shoulder is trying to launch from wet sand. The arm still moves, but the platform underneath it is sliding. A person may first notice it after trauma, repetitive strain, or surgery near the neck, chest, or shoulder. Sometimes there is pain. Sometimes there is almost none. Just weakness and a blade that refuses to stay flat. Targeted rehabilitation may help restore muscular control, but the correct exercises depend on which muscle or nerve is involved. New winging after an injury or operation, worsening weakness, numbness, or major loss of movement deserves a professional assessment. The goal was never to hide a bone that looks different. It is to give the whole shoulder its platform back. Strabismus. Two eyes can stare at the same object and still send the brain two different worlds. One eye locks onto the target. The other turns inward, outward, upward, or downward. It is easy to notice the direction. The part you cannot see is what the brain does next. Your eyes normally capture two slightly different images. The brain fuses them into one scene, using the difference between them to help build depth perception. It is a quiet partnership happening every second. Strabismus breaks that partnership. In an adult whose eyes suddenly become misaligned, the brain may keep both images, creating double vision. But a young child's developing brain can choose a different escape route. To avoid confusion, it may begin suppressing the image from the deviating eye. That sounds helpful. It is not. The eye may be physically capable of seeing, but the brain gradually stops using its signal. This can lead to amblyopia, often called lazy eye. The name is misleading. The eye is not lazy. The visual system has learned to silence it, and that is the real danger hiding behind the alignment. Imagine a child who turns her head every time she watches television. Her family assumes it is a quirky habit, but she may be searching for a position where the two images line up more comfortably. Another child may close one eye in bright light, misjudge steps, lose their place while reading, or avoid tasks that demand precise depth. Some people have constant strabismus. Others drift only when tired, ill, distracted, or focusing at a particular distance. The direction and timing matter because strabismus is not one single malfunction. Focusing problems, eye muscle control, nerve function, and visual development can all shape the pattern. Treatment may include glasses, prisms, patching, atropine drops, vision-based therapy in selected cases, or surgery that changes how the eye muscles pull. Patching does not straighten the eye by itself. Its main purpose is often to strengthen visual use of an amblyopic eye. Surgery can improve alignment, but the brain may still need help learning to use both eyes together. Strabismus is not someone failing to look straight. It is the eyes and brain losing the same conversation. Flat feet. You step out of the shower, leave a full footprint on the floor, and suddenly your feet are declared defective. Not so fast. The shape is only the first clue. The real question is whether the arch can still do its job. A foot arch is not a stone bridge frozen in one position. It is a moving structure built from bones, ligaments, muscles, and tendons. When your foot accepts body weight, the arch lowers slightly to absorb force. As you push forward, it stiffens again and turns the foot into a lever. It is part shock absorber, part spring, part launch pad. In flexible flat foot, the arch may disappear while standing and return when the foot is unloaded or when the person rises onto the toes. Many people have this shape without pain, weakness, or disability. A low arch by itself is not proof that something is broken. But there is another kind of flat foot, and this is where the footprint stops being harmless. The posterior tibial tendon, post-tier E or TBEL, runs behind the inner ankle and helps support the arch. In progressive collapsing foot deformity, this tendon and other supporting structures may lose their ability to hold the foot in alignment. The arch drops, the heel drifts outward, and the front of the foot may rotate away from the body. The bridge is not merely low. One of its main support cables is failing. An early clue may be pain or swelling behind the inner ankle. Later, standing on one tiptoe can become difficult because the posterior tibial tendon helps lift the heel and turn it inward. As the deformity progresses, the pain may shift toward the outer ankle, where bones and soft tissues begin crowding each other. Now, picture two people with almost identical footprints. One walks, runs, and works without pain. The other develops a changing arch, ankle swelling, and increasing stiffness. Same silhouette, completely different story. That is why treatment should follow function and symptoms, not just appearance. Supportive shoes, activity adjustments, stretching, braces, or orthotics may help in some cases. A newly collapsing arch, persistent pain, major stiffness, or difficulty walking deserves assessment before the foot becomes harder to realign. A flat foot does not automatically need fixing. A foot that is changing is asking to be understood. Goiter. A swelling at the base of the neck can look like one simple problem. It is not. A goiter tells you the thyroid has grown. It does not tell you what the thyroid is doing. The thyroid is a butterfly-shaped gland wrapped around the front of the windpipe. Its hormones help regulate how quickly the body uses energy. But when the gland enlarges, hormone production can be too high, too low, or completely normal. That is the first trap. You cannot read thyroid function from neck size alone. The enlargement may spread through the whole gland, creating a diffuse goiter, or the thyroid may grow unevenly, producing one or more nodules. In iodine deficiency, the gland may enlarge because it lacks a key raw material needed to make thyroid hormones. It is like a factory expanding its floor space because the supply truck keeps arriving empty. But iodine is only one possible cause. Graves' disease can drive the thyroid into overproduction through stimulating antibodies. Hashimoto's disease can inflame and gradually damage the gland. Thyroiditis, nodules, and less commonly, cancer can also change its size. And the real giveaway may not be the swelling itself. An overactive thyroid can bring a racing heart, heat intolerance, tremor, or unexplained weight loss. An underactive thyroid may bring fatigue, cold sensitivity, dry skin, or weight gain. A person with normal hormone levels may notice none of those, only a collar that suddenly feels tighter. A large goiter can also press on its neighbors. The windpipe sits directly behind it. The esophagus is close by. That is why some people develop coughing, hoarseness, difficulty swallowing, or a sense of pressure when lying down. The gland may be small in the mirror, but extend deeper into the chest, where appearance reveals even less. Evaluation often combines a neck examination with blood tests, such as thyroid-stimulating hormone, or TSH, and thyroid hormone levels. Ultrasound can show whether the enlargement is diffuse or nodular. Depending on what appears, clinicians may use antibody tests, imaging, or a fine needle biopsy to examine a suspicious nodule. Treatment is aimed at the cause, not merely the silhouette. Some goiters only need monitoring. Others require treatment for abnormal hormone production, iodine deficiency where medically appropriate, or surgery when size, compression, or concerning nodules become the real issue. A goiter is not a diagnosis written on the neck. It is the thyroid asking a deeper question. Lordosis. Look at the lower back from the side. A curve is supposed to be there. The problem is not that the spine bends inward. The problem begins when the curve, its cause, or its effect stops being normal. The cervical spine in the neck and the lumbar spine in the lower back naturally curve toward the front of the body. That inward curve is called lordosis. It helps place the head and torso over the pelvis while distributing force during standing and movement. A perfectly straight spine would not be better. It would handle impact like a rigid pole. So the word lordosis itself does not automatically mean a disorder. What people usually mean is hyperlordosis, an exaggerated inward curve, often in the lower back. But even then, the visible arch is only the beginning of the story. And the real clue is whether the curve is flexible. In a flexible pattern, the curve may reduce when a person bends forward, changes position, or brings the knees toward the chest. In a fixed deformity, the spine does not correct easily. That difference matters because one pattern may be driven largely by posture or muscle imbalance, while another may involve structural changes in the vertebrae, hips, or surrounding tissues. The pelvis is one of the hidden players. When it tilts forward, the lower spine often curves more deeply to keep the torso balanced. Tight hip flexors can pull the front of the pelvis downward. Weak or poorly coordinated abdominal and gluteal muscles may provide less counterforce. The body is not posing dramatically. It is stacking itself wherever balance is cheapest. Now picture a person standing with the abdomen pushed forward and the buttocks appearing more prominent. That shape may come with no pain at all. Another person with a similar outline may develop lower back fatigue, muscle tightness, or discomfort after standing. Same photograph, different mechanics. Hyperlordosis can also appear alongside conditions such as spondylolisthesis, in which one vertebra slips relative to the one below it. Hip contracture, certain neuromuscular conditions, and skeletal disorders can also alter spinal alignment. That is why blaming every exaggerated curve on bad posture can miss the structure. Underneath, assessment may include observing the curve during different movements, checking hip flexibility and muscle function, and using imaging when pain, rigidity, neurological symptoms, or a structural disorder is suspected. Treatment may involve exercises aimed at mobility, strength and control, but the program should match the cause rather than forcing every spine into one ideal shape. Severe pain, leg weakness, numbness, changes in walking, or loss of bladder or bowel control requires prompt medical attention. The goal was never to flatten every curve. It is to make sure the curve is still working for you. Port wine stain. A red or purple patch is present from birth, so it can look as though color was spilled beneath the skin. But this is not pigment. And the most important clue is not how dark the mark looks. It is where the mark appears. A port wine stain is a capillary malformation. Tiny blood vessels close to the skin remain wider than usual, allowing the blood inside them to create a flat pink, red, or purple patch. Unlike a bruise, nothing leaked after an injury. The vessels themselves form the color. Think of it as a map drawn in capillaries. The mark often begins smooth and pale, but unlike some infant birthmarks, it usually does not fade away on its own. As the person grows older, it may darken, thicken, or develop a rougher surface. The patch is not spreading like an infection. The same abnormal vessels are simply changing with time. Now imagine a child with a stain crossing the forehead and upper eyelid. To everyone else, it may seem like a visible difference and nothing more. But to a doctor, that location changes the question. Most port wine stains affect only the skin. However, certain facial patterns around the forehead or eye can be associated with Sturge-Weber syndrome, which may involve abnormal vessels around the brain, or with eye problems such as glaucoma. That does not mean every facial mark hides a deeper condition. It means the map tells doctors where to look more carefully. When treatment is chosen, pulsed dye laser can target hemoglobin inside the abnormal vessels and lighten the mark while limiting damage to nearby skin. Several sessions may be needed, and complete removal is not guaranteed. The mark was never just color on the skin. It is a vascular map, and sometimes its location reveals what the mirror cannot. Bow legs. Stand with your feet and ankles together. If your knees remain apart, your legs form the curve doctors call genu varum. Genu varum. It can look like the bones are growing the wrong way. But in a young child, that curve may be part of growing normally. Babies spend months folded inside the uterus. Their legs often begin life bowed, then gradually change alignment as they grow and start walking. In many children, the curve improves naturally during the first few years, and the real clue is not simply how wide the gap looks. It is whether the curve is improving, staying fixed, or becoming uneven. Think of the legs as two columns being slowly adjusted while the building is still under construction. Normal bowing is usually similar on both sides, but one leg curving more than the other, bowing that worsens, or a curve that persists beyond the expected age can point to something else. Blount's disease affects the growth area near the top of the tibia, TIBE, causing the shin bone to angle inward as the child grows. Rickets can also soften developing bone when mineralization is impaired, making the legs bend under body weight. Now imagine two children with the same gap between their knees. One is a toddler whose legs are slowly straightening. The other has one leg becoming more curved each month. Same silhouette, completely different direction. That is why doctors look at age, symmetry, walking pattern, progression, and sometimes X-rays, not just the space between the knees. Physiologic bowing may only need observation. A persistent or progressive deformity may require treatment aimed at the cause. The goal was never to force every child into perfectly straight lines. It is to know whether growth is correcting the curve or creating it. Bifid Uvula. Open your mouth and look at the small piece of tissue hanging at the back of your throat. Sometimes, instead of one tip, it splits into two. It can look like a tiny cosmetic variation. And often, that is exactly what it is. But the real clue is not the split itself. It is what may be hiding underneath the roof of the mouth. The uvula is part of the soft palate, a muscular curtain that lifts during swallowing and speech. Its job is to help close the passage between the mouth and the nose. When that seal works, food goes downward, and speech sounds clear instead of leaking through the nasal cavity. A bifid uvula forms when the tissues in the midline do not fuse completely during development. In many people, it causes no symptoms at all. But sometimes it is the visible tip of a submucous cleft palate. Think of a ceiling that looks intact because the wallpaper is still there, while the support beams underneath never fully joined. In a submucous cleft, the lining of the palate covers the gap, so the cleft may be difficult to see. Other clues can include a pale or bluish line along the middle of the palate, a small notch at the back of the hard palate, feeding problems, or liquid escaping through the nose. And this is where the early clue returns. A child may develop nasal-sounding speech because the soft palate cannot seal firmly against the back of the throat. Some may also experience hearing problems linked to poor middle ear ventilation. But a split uvula alone does not prove that a hidden cleft is present. It simply tells clinicians to look and listen more carefully. If speech, feeding, or hearing develops normally, no treatment may be needed. When problems appear, assessment may involve a cleft palate team, speech specialist, or ear specialist. A bifid uvula is not automatically a defect that needs fixing. Sometimes it is just a fork in the tissue, and sometimes it is a sign to look beneath the surface. Lipoma. You find a lump beneath the skin. It feels soft, and when you press it, it slips slightly beneath your fingers. That movement is reassuring. But it is not the whole diagnosis. A lipoma is a slow-growing mass made of mature fat cells, usually sitting in the layer between the skin and the muscle. It often feels soft or rubbery, moves with gentle pressure, and causes little or no pain. Think of it as a small cushion of fat growing inside its own thin envelope. And the real clue is not simply that the lump contains fat. It is how the lump behaves over time. A typical lipoma may remain almost unchanged for years. It does not appear because someone gained weight, and losing weight does not reliably make it disappear. Ordinary body fat shrinks when energy is used. A lipoma is a separate growth with its own boundaries. Now imagine someone named Daniel noticing a grape-sized lump on his shoulder. It moves easily, never hurts, and barely changes for 5 years. Then imagine another lump that becomes noticeably larger within months and feels anchored deep beneath the tissue. Both may be painless, but they are not telling the same story. Most lipomas are benign, and many need nothing beyond observation. But a lump that grows quickly, becomes hard or fixed, causes persistent pain, feels deep, or affects movement deserves proper assessment. Rare soft tissue cancers can also begin as painless lumps, which is why touch alone cannot provide complete certainty. When the diagnosis is unclear, imaging such as ultrasound or MRI may help show its depth and structure. A biopsy can identify the tissue directly. If a confirmed lipoma becomes painful, presses on nearby structures, restricts movement, or causes significant concern, it can often be removed surgically. A soft lump may feel harmless, but every new lump should earn its name before it earns your trust. Pectus Carinatum. The center of the chest pushes outward, making the breastbone look as if it is trying to leave the rib cage. It can seem like one bone simply grew too far forward. But the real change begins where the ribs meet the sternum. Pectus carinatum is a chest wall deformity in which the sternum and nearby ribs project outward. The costal cartilage, the flexible material connecting the ribs to the breastbone, grows in a pattern that pushes the front of the chest forward. Think of a tent frame where several support rods became slightly too long. The fabric is not the problem. The frame underneath is changing the shape. And the most important clue is not how far the chest sticks out. It is whether the chest wall is still flexible. The prominence often becomes more noticeable during adolescence, when the rib cage is growing quickly. It may affect both sides evenly, or one side may project more than the other, creating a rotated appearance. Some people notice tenderness when lying on the chest, shortness of breath during exercise, or reduced stamina. Others feel physically fine, but become intensely aware of the shape every time they change clothes or enter a swimming pool. Now imagine two teenagers with a similar outward curve. One has a chest wall that compresses gently under pressure. The other has a rigid prominence that barely moves. Same outline. Different treatment window. When the chest wall is still flexible, a custom compression brace can apply steady pressure and gradually guide its growth. The process often takes months or longer, and consistency matters because the brace is reshaping a living structure, not flattening a dent in metal. Surgery is usually reserved for more severe, rigid, or complex cases. Pectus carinatum can also occur alongside connective tissue conditions, such as Marfan syndrome. So unusual body proportions, joint flexibility, or a family history may lead clinicians to look beyond the chest itself. The goal was never to punish a chest for growing differently. It is to guide the frame while it can still change. Torus Palatinus. You run your tongue across the roof of your mouth and find a hard bump sitting directly in the middle. It feels like something grew where nothing should be. But in most cases, it is not a tumor, and it is not dangerous. The real clue is not simply that the bump is hard. It is where it sits, how slowly it appeared, and whether it begins to change. A Torus Palatinus is a benign overgrowth of bone along the midline of the hard palate. It may be smooth, lobulated, broad, or divided into several smaller ridges. Unlike a cyst, it does not feel soft or fluid-filled. Press it, and it feels like part of the skull, because it is. Think of it as the roof of the mouth building an extra support beam nobody ordered. The exact cause is not fully understood. Genetics appears to play a role, while mechanical stress from chewing or clenching may also contribute. It can be present early or become more noticeable over time, often discovered by accident during a dental examination. And here is where that thin layer above the bone matters. A torus is covered by delicate oral tissue with very little padding underneath. Hard food, sharp chips, or dental instruments can scrape it easily. The bone itself may be harmless, but the skin stretched across it behaves like wrapping paper over a rock. Now imagine two people with the same hard bump. One has had it for years without pain. The other develops an ulcer that does not heal, sudden enlargement, bleeding, or a new change in shape. Same location. Different reason to pay attention. Most palatal tori need no treatment. Removal is usually considered only when the growth interferes with speech, swallowing, dental appliances, or repeatedly becomes injured. But a new, painful, rapidly changing, or ulcerated mouth growth should be examined rather than assumed to be harmless. The bump may be extra bone. The important part is knowing when it stops behaving like ordinary bone. Kyphosis. The upper back rounds forward, so everyone tells you the same thing. Stand up straight. That may work for posture. It cannot reshape a vertebra. The thoracic spine naturally curves backward. That curve helps distribute force and balances the chest over the pelvis. Kyphosis becomes a problem when the rounding grows excessive, painful, rigid, or progressive. And the real clue is not how hunched the back looks. It is whether the curve disappears when the person tries to correct it. Postural kyphosis is usually flexible. A teenager may slump over a desk like their spine is folding around a phone, then straighten when asked. The bones themselves are generally shaped normally. Schormann's kyphosis is different. Several vertebrae become wedge-shaped during growth, turning the upper spine into a more rigid arc. The person is not refusing to stand straight. The structure itself will not fully unfold. Now imagine two students with nearly identical rounded backs. One straightens the moment they lift their chest. The other stays curved, even when trying hard. Same silhouette. Different spine. In older adults, another mechanism can appear. Osteoporosis may weaken vertebrae until they compress, reducing height and increasing the forward curve. It is less like slouching and more like the front edge of several building blocks slowly collapsing. Mild kyphosis may need only observation, exercise, or physical therapy. A growing child with Schormann's kyphosis may sometimes use a brace while the skeleton is still developing. Severe pain, rapid progression, weakness, numbness, walking changes, or breathing difficulty deserves medical assessment. The goal was never to shame someone into standing taller. It is to learn whether the curve can move or whether the bones are holding it there. Which sign surprised you most? Tell us in the comments, and stay tuned for the next video by liking and subscribing to the channel. Thank you for watching.